Hello, I'd like to welcome you today to the KFF Women's Health Policy Update. I'm Alina Selyanikoff, Senior Vice President and Director of Women's Health Policy at KFF. Over the past year, we at KFF have been following a broad range of federal and state actions, legislation, and litigation that have the potential to reshape policies that affect the lives of millions across the nation. Abortion, contraception and family planning, maternity care, and paid leave are often considered by our policymakers in separate silos with distinct rules and policies. But taken together, the implications of those policies ultimately will affect the ability of people to decide whether and when to have a child and their ability to raise children in a way that supports their health, education, as well as their economic opportunities and well-being. Our goal today is to provide you with a general update on the recent developments and implications of 4 distinct but interconnected health policy issues that are central to women's health. Before I get started, however, I wanted to be clear that while we are speaking of women's health, it is our intention to be as inclusive as possible of transgender men and women, gender fluid and non-binary individuals, and others who are also going to be affected by the policies and programs that we're going to discuss today. In some cases, we're going to be citing data that uses labels that we cannot change without misrepresenting the data or the laws as written. I'd also like to let you know that this web briefing is being recorded and will be posted online at KFF later today. All registrants will be notified via email when the recording becomes available. We have a lot of ground to cover today in a short time. In recent months, our nation's eyes have been riveted on Texas and Mississippi laws and the possible actions that a solidly conservative Supreme Court could take in 2 challenges to laws that could undermine the constitutional right to abortion. On November 1st, the court heard oral arguments in a challenge to a 6-week abortion ban in Texas that had been allowed to take effect, even though it violates people's constitutional right to abortion in that state. In a few weeks, the Supreme Court will hear oral arguments in a case arising from a Mississippi law that bans abortions after 15 weeks, and for the first time is directly challenging Roe. Laurie Sobel, an attorney and KFF Women's Health Policy Associate Director, will provide an overview of the case and the current status of state abortion laws, as well as discuss potential rulings and implications. She will be followed by Brittni Frederiksen, KFF Senior Policy Analyst, who has been closely tracking the status of the federal Title X family planning program from even before the Trump administration issued regulations that resulted in the loss of a substantial share of clinics that were participating in the program. Those regulations disqualified family planning providers that also provided abortion services or who were unwilling to participate in a program that would force them to deny referrals to abortion care for pregnant people who sought them, and mandated that they all be provided with referrals to prenatal care. This affected many family planning providers that had long been in the Title X network, serving low-income people, and most notably targeted Planned Parenthood. The Trump regulations were challenged by attorneys generals from over 20 states in a case that nearly made it to a Supreme Court hearing before it was dismissed by the court. Last week, a new Biden administration rule that reverses the Trump regulations took effect. But the network will take time to rebuild, and now a dozen states are challenging the Biden regulations. Brittni is going to give you an update of the, I'm sorry, my computer is having a bit of a problem right now. Brittni's going to provide an update on the status of the Title X network and the Biden regulations, as well as the current legal challenges. Then we're going to focus on 2 provisions of the Build Back Better Act that could strengthen the safety net for pregnant and birthing people: the Medicaid postpartum extension and paid family leave. Usha Ranji, Women's Health Policy Associate Director, will provide an overview of the role of Medicaid in maternity care and discuss gaps in coverage and the provisions of the balanced budget of the Build Back Better Act that are designed to improve and stabilize coverage, as well as address some of the factors contributing to the major disparities in maternal outcomes that affect many pregnant and birthing people, particularly women of color. We will then wrap up the presentations with Michelle Law. Michelle is a senior policy analyst who has been tracking advances in paid family leave benefits across the country, and most recently has been following the saga of the paid leave provisions in the reconciliation bill. Michelle will provide an update on the status of paid leave laws in the US and brief you on what's left in the reconciliation bill. Next slide, please. We are then going to leave some time for questions. I encourage you to submit your questions by putting them on the questions functioning through the Zoom app on the bottom of your screen. Feel free to do that throughout the presentations. With that, now I'm going to turn to Laurie Sobel.
Thank you, Alina. I'm going to walk through the federal constitutional right to abortion and the role of state laws and policies. The Supreme Court, as you can see on the slide, has considered many cases involving abortion, but I'm going to highlight Roe and Casey. As probably all of you know, the Supreme Court established the constitutional right to abortion before viability in the case of Roe v. Wade in 1973. Viability, the point at which the fetus can survive outside the womb, is determined by the patient with their doctor and is assumed to be around 24 weeks. In the case of Planned Parenthood v. Casey in 1992, the court established a new test for evaluating state abortion regulations before viability. States are permitted to regulate abortion before viability as long as the regulation does not place, quote, an undue burden on women seeking an abortion. Next slide, please. Since the Casey decision in 1992, many states have enacted a wide range of restrictions such as counseling, ultrasound, waiting periods, parental notification, and consent requirements, as well as regulations specific to facilities and clinicians providing abortions. And you can see just a sampling of some of these restrictions on this slide and how many states have each of them. Next slide, please. In addition, there are federal and state restrictions for payment of abortion coverage. The Hyde Amendment has been reenacted every year since 1976. It restricts the use of federal funds to pay for abortion only when the pregnancy is the result of rape or incest or the pregnant person's life is endangered. As seen in this map, the orange states restrict their state Medicaid to covering abortion to the circumstances permitted by Hyde. The darker the orange, the more restrictions states have in the ACA marketplace plans and private insurance plans. These restrictions place the most burden on low-income people and people of color trying to access abortion care. The blue states, on the other hand, require coverage in Medicaid, private, and ACA marketplace plans. Next slide, please. So the case that's before the Supreme Court this term, specifically around Roe v. Wade, is Dobbs v. Jackson Women's Health. It's a 15-week gestational ban from Mississippi, and it will be heard at the court on December 1st. And I'm going to walk through the arguments from each side. Mississippi is asking the Supreme Court specifically to overturn the constitutional right to abortion as established by Roe. They contend that Roe and Casey were both decided incorrectly. They claim the state has an interest in protecting potential life both before and after viability, but the standard set in Roe prohibits it from protecting life before viability. In addition, they contend that abortion is no longer necessary for women to participate equally in economic life because contraception is widely available. Jackson Women's Health contends that the court is bound by the precedents of Roe and Casey, and that contraception is not universally available and it's not fail-safe, and that we have not met the gender equality that Mississippi is claiming that we've met. As a fallback position, Mississippi is saying if the court is not willing to allow states to ban all abortions pre-viability, they should allow states to ban some abortions before viability. And they'd like the court to apply the undue burden standard set up in Casey, which in the past has only been applied to abortion regulations. And they are contending that if they apply the undue burden standard in this case, this 15-week ban is not an undue burden because only 4.5% of the women in Mississippi obtain abortions past 15 weeks gestation. So it doesn't burden a significant number of women seeking abortions, is their contention. Jackson Women's Health then counters that it doesn't matter if it's just one person, that the very essence of a constitutional right is that the government cannot outright prohibit a certain subset of people, no matter how small, from exercising that right. So even if just one person cannot access their abortion because of this ban, the law is unconstitutional. Next slide, please. So how might the court decide this case? There's essentially three possibilities. The first is that they overturn Roe v. Wade completely and allow states to ban any abortion at any point in pregnancy. The second possibility is this fallback position that Mississippi is asking for, which is saying that they would allow states to ban abortion pre-viability when the ban does not burden a substantial number of people seeking abortion care. Let me be clear that if they decide this decision, this is still overturning Roe v. Wade, it just has a little bit more nuance in terms of what states would be allowed to do. And it would be interesting to look to see how the Supreme Court figures out the denominator in this equation, because as I said, Mississippi is claiming only 4.5% of people in Mississippi have obtained abortions past 15 weeks. But that doesn't count the people that traveled out of state to seek their abortion care, or perhaps those people who went without abortion care because they were not able to access it. The final possibility is the Supreme Court upholds Roe v. Wade and does not permit states to ban pre-viability abortions. Given what we know about the court at this moment, this seems very unlikely. The Supreme Court will likely issue its decision at the end of the term in June of 2022. Next slide, please. So what happens if the Supreme Court overturns Roe v. Wade and allows states to ban abortion before viability? Well, many states would seek to ban abortion. As seen in this map, the dark blue and black states have laws intended to limit abortion to the maximum amount permitted by federal law. On the other hand, the green states have laws protecting abortion before viability. The states with the asterisks have a state Supreme Court decision that established a state constitutional right to abortion. So we would likely see new litigation after states react to this decision by either passing laws banning pre-viability abortions or some subset of pre-viability abortions, or protecting the right to pre-viability abortions. But this time, the litigation would likely be in state courts, and it would be up to the state Supreme Courts to either reaffirm the previous decision that the state constitution protects abortion or overrule that decision. Next slide, please. While there's been a lot of attention on the Supreme Court and Texas, the Texas case is not about the constitutional right to abortion right now. Dobbs is the case where the court will consider Roe v. Wade. SB 8 has been in effect since September 1st. The law allows any person to bring a civil action against any person who performs or aids or abets an abortion performed after a fetal heartbeat is detected, about 6 weeks since the last menstrual period. The unusual nature of the enforcement of this law, not by the state, but by private individuals, has made the litigation trying to block the enforcement of the law more challenging. The clinics and the Department of Justice have sued. As Alina mentioned, the Supreme Court heard oral arguments on November 1st, again, not about Roe, but about whether the litigation can continue. One study has looked at the impact of the law so far and found a 50% drop of legal abortions comparing September of 2021 to September of 2020. But remember, the pandemic impacted access in September of 2020. And as the law continues to remain in effect, access will likely get harder. Other states are also seeing an increase in demand with people traveling from Texas to their states. So there's a lot of speculation about whether the Supreme Court's decisions to allow the Texas law to take effect and remain in effect, if that predicts the court's decision in Dobbs. But remember, the court was not directly considering the constitutionality of pre-viability abortion bans, as the court will have to do in Dobbs. Next slide, please. So there have been some policy proposals at the federal level to try and ensure access to abortion. First, the Women's Health Protection Act, which would create a federal statutory right for healthcare providers to provide abortion care and a right for patients to receive abortion care, and would ban many current state restrictions. It passed the House in late September, but there's no clear path in the Senate. And for the first time in 45 years, the House passed an appropriations bill without the Hyde Amendment. But again, this is not likely to get through the Senate. I'm going to stop there and I'm going to turn it over to my colleague Brittni, who will go over the recent changes in Title X.
Thanks, Laurie. Hi, everyone. My name is Brittni Frederiksen, and I'm a senior policy analyst on our team. I'll be talking about the Title X program and how attempts have been made to restore and improve access to family planning care. Next slide, please. So I'll start by giving a little background of the Title X program for those who are less familiar. Title X is the only federal grant program specifically dedicated to the provision of family planning services, and it's been in existence since 1970. The program is administered by the Office of Population Affairs within the U.S. Department of Health and Human Services. And the Title X program has historically set the standard for providing quality family planning services based on recommendations of the CDC and the Office of Population Affairs. These are known as QFP, or Quality Family Planning Recommendations. The program has been funded at $286.5 million per year since 2015, you'll see on the right. And it's historically served around 4 million low-income, uninsured, and underserved clients each year. Title X grantees have been funded in all 50 states, DC, and US territories, supporting approximately 4,000 clinics nationwide. The fiscal year 2022 House and Senate spending bills have increased funding levels for Title X. The House increased to $400 million, and the Senate proposed $500 million for Title X. So this would be the most that the program has ever received. Next slide, please. So this was the way the program was prior to the Trump administration, but the Trump administration issued regulations in 2019 that drastically changed the program. Mainly required financial and physical separation of abortion services for sites that did offer abortion. They also prohibited Title X clinics from referring pregnant clients who were seeking abortions to abortion providers, known as the gag rule. They required all pregnant clients to be referred to prenatal care, even if they sought an abortion. And they encourage participation by non-traditional organizations, trying to broaden the network to those organizations that were faith-based or only offered abstinence or fertility awareness, rather than a broad range of contraceptive methods. These regulations were challenged by 24 states under 4 different lawsuits, highlighted in different colors here on the map on the right. And they were allowed to go into effect by the Ninth Circuit across the country, except the US Court of Appeals for the Fourth Circuit blocked the rule in Maryland. So Maryland was the only state where the Trump regulations were not in effect. Because of these regulations, a number of sites left the network, and Planned Parenthood clinics specifically that made up 10% of the network decided to leave the program. Next slide, please. So this is the map of what the network looked like prior to the Trump regulations in June 2019, approximately 4,000 sites across the US in every state. Next slide, please. And then this is what the network looked like after the Trump regulations went into effect. These are the sites that chose to leave the program. It was over 1,000 sites, which was over 25% of the network. The purple sites are the Planned Parenthood clinics that left, and the orange sites are those other sites that left. You can see the East Coast and West Coast were disproportionately affected. Next slide, please. And then here's the map. Most recently, this was done in August 2021. You'll see that the gray sites are sites that have still not rejoined the program. So we still have large gaps across the country where there are no Title X clinics. The light blue are the sites that have had no change. The dark blue, some states have joined or allowed new sites to join. And then in the yellow, a few sites have rejoined, specifically in Maryland, where the rules were not in effect, as well as a Utah grantee, the Utah Navajo Health System, that's rejoined as a subrecipient under Arizona's grantee, Arizona Family Health Partnership. A few Planned Parenthood sites have joined in Maryland, DC, and Missouri as well. Next slide, please. So the combination of the Trump administration final rule plus the COVID-19 pandemic resulted in a marked decrease in clients served by Title X. As I said earlier, the program normally serves 4 million clients, and in 2020 only was able to serve 1.5 million clients. This was a 60% decrease in clients served. And this disproportionately affected the people that access these services. So 300,000 fewer uninsured clients were served, 800,000 fewer low-income clients. Next slide, please. So the Biden administration has made efforts to restore the program through new regulations that were made effective last week on November 8th. They now allow co-located abortion services and abortion referrals. They require clinics to provide a broad range of family planning methods or a prescription or referral if requested. And pregnant clients, once again, have the option to receive options counseling, whether that be adoption, prenatal care, or abortion referrals if they desire it. There's also some new additions to the regulations that allow confidentiality protections for adolescents or add additional confidentiality protections for adolescents. They include telehealth as an option for providing medical services. They require services are provided in a client-centered, culturally and linguistically appropriate, inclusive, and trauma-informed manner. And they've also added a new funding criterion that grantees are required to demonstrate the ability to advance health equity. Next slide, please. The Biden administration regulations have not been without lawsuits. On October 25th, the state of Ohio and 11 other states highlighted in red on the right filed a lawsuit to block the implementation of the new Biden administration's regulations. These states are claiming that the final regulations violate Section 1008 of the Public Health Service Act that says none of the Title X appropriated funds can be used in programs where abortion is a method of family planning. It's worth noting that no court has found the decades-long practice of abortion referral upon request to violate this prohibition. The states are requesting a ruling as soon as practicable and no later than December 31st, 2021, but the rules are in effect as of November 8th. Next slide, please. So there's been a number of funding opportunities announced to help to restore the program as well. If the HHS budget is approved, there will be a sizable increase for Title X in funding where new sites could be added or networks could be expanded. The notice of funding opportunity for the Title X Family Planning Service grants was announced on October 27th, and sites have until January 11th to apply for funds. This is a large portion of the Title X budget, $256 million that will go to these sites, and funds will probably be awarded around April, so a little bit of time. There was an additional $9.25 million estimated through a NOFO for 10 grantees in areas with dire need for family planning services. So these could be states that currently don't have Title X service sites or grantees. They could also be states that have had an influx of patients because of Texas's SBA abortion ban that Laurie talked about. And HHS has awarded additional funding to Texas because of SB8. And then finally, another NOFO is anticipated. $45 million is planned this spring to expand and enhance telehealth infrastructure and capacity among Title X grantees. And this is in response to the expansion of the mode of service delivery during pandemic that we all have become used to, telehealth. So this new funding and the new regulations will be one step in restoring the Title X network, though HHS anticipates that it'll likely take at least 2 years to rebuild the network. And with that, I'll pass it over to my colleague, Usha Ranji.
Thanks, Brittany. Hello, everyone. Next slide, please. So the area of maternal health is receiving long overdue attention in the US now, in part because of the more than 700 annual deaths that occur within 1 year of pregnancy and the stark racial and ethnic disparities. The pregnancy-related mortality rate is 3 to 4 times higher among Black birthing people compared to other populations. And the rate is also significantly higher among American Indian and Alaska Native populations. We know that many of those deaths are preventable. The root causes of pregnancy-related mortality and morbidity are layered and include larger social factors, including racism, biases in the healthcare system and access to care, as well as poverty. And on the policy front, there have been a variety of federal, state, and local efforts to address some of these issues. Improving research and data collection, there's been support for clinical quality improvement at the provider level. And these have made differences in some areas, but on the whole, large racial and ethnic inequities remain. Health insurance coverage is another area where we're seeing a lot of work, and I'm going to focus specifically on Medicaid's role in maternity coverage. Next slide, please. The Medicaid program is the health coverage program for low-income families. Nationally, it finances more than 4 in 10 births. And as you can see on the map here, in several states, it's more than half. The program is operated jointly between the federal government and states. States must cover maternity services in their benefits package, and they must cover all pregnant people with incomes up to 138% of the poverty level. That's about $30,000 a year for a family of 3. Infants born on the program are covered through the first year of life, but under longstanding federal law, Medicaid coverage for the birthing individual ends 60 days postpartum. Now, we are currently operating under a federal public health emergency due to the COVID pandemic. Because of that, no one is being dropped from the Medicaid rolls after the postpartum period at this time. Next slide, please. Medicaid plays an even larger role in covering births for women of color. Medicaid covers about 2/3 of births among Black, American Indian, Alaska Native, Native Hawaiian, and Pacific Islander people, and just over 6 in 10 births among Hispanic people. And that's compared to 1 in 3 births among white and 1/4 of Asian individuals. Next slide, please. States set the income eligibility levels for Medicaid, and the Affordable Care Act of 2010 allowed states to expand eligibility for all citizens up to 138% of the poverty level. That's that same minimum threshold as for pregnancy coverage. Most states to date, 38 as well as DC, have expanded Medicaid eligibility as allowed under the ACA. But the 12 states in orange here on this map have not expanded, which means that qualifying for Medicaid in those states remains in the pre-ACA world with different income eligibility levels for different categories of beneficiaries, which affects access to coverage before and after pregnancy. Next slide, please. We can see what that means here. Here, these are all states that have expanded Medicaid under the ACA and their income eligibility levels for pregnancy. Again, Medicaid must cover pregnant people with incomes up to 138% of the poverty level, but most states set their thresholds well above this. So after 60 days postpartum, people with incomes up to 138% of poverty can remain on Medicaid because of the ACA expansion up to this level. That's the blue bars that you see. And in the beige, those who had Medicaid funded births with higher incomes up to 400% of poverty can qualify for subsidies for private insurance in the ACA marketplaces. So all that is to say that there is a pathway to coverage and assistance for postpartum people in expansion states. Next slide, please. But in the non-expansion states, it's a different story. In dark blue are the Medicaid income thresholds for pregnancy. Like expansion states, most set them above the minimum requirement. However, in these states, after 60 days postpartum, Medicaid coverage for pregnancy ends, and then birthing people would have to qualify as parents to remain on the program. And in the light blue, you have the eligibility cutoffs for parents, which, as you can see, are much lower than for pregnancy. For example, in Alabama, the parent eligibility threshold is 18% of the poverty level. That's less than $4,000 annually for a family of 3. So for a person there who's had a baby, if she and her partner have earnings above $4,000 a year, she could lose Medicaid coverage just 2 months after having a baby. Now, just as I showed in the last slide, the marketplace subsidies are available for those between 100 and 100 and 400% of poverty. But for those below 100%, there's a coverage gap where new parents with incomes above the very low parent levels, but still below the poverty line, do not qualify for Medicaid or federal marketplace subsidies in these states and could become uninsured. Currently, Congress is actually considering a new plan to help fill the coverage gap in these states. Next slide, please. And recently, there has been a lot of attention on strengthening the postpartum period, which is a critical time for recuperation and follow-up on health conditions. Earlier this year, Congress enacted the American Rescue Plan, which made a significant change by giving states the option to extend Medicaid postpartum coverage from 60 days to 12 months. To take up the option, states would have to amend their state plans, and the extension could take effect next April and last for 5 years. KFF has been tracking this, and a number of states have expressed interest in lengthening the postpartum period. Some through this new federal option, but some are also taking different approaches. For example, Georgia has received federal approval to extend the postpartum period to just 6 months. And Missouri is doing a 1-year extension postpartum for those postpartum people with substance use disorders. And there are some non-expansion states that have not proposed any changes to postpartum coverage. So Medicaid coverage in those states remains status quo and would end 2 months after delivery, again, once the COVID public health emergency is over. Next slide, please. But broader change may be on the horizon. Like Alina mentioned, Congress is considering the Build Back Better legislation, which includes changes to the Medicaid program that would affect maternity coverage. So the first proposal would require Medicaid pregnancy coverage to go through 1-year postpartum in all states. That would affect both expansion and non-expansion states. The legislation also would allow people living in states that have not expanded Medicaid to temporarily purchase subsidized plans on the ACA marketplaces, which could provide coverage for those that are currently in the coverage gap. And of course, improving maternal health is much bigger than health coverage. The federal legislation also proposes to increase funds for a number of related areas, such as support for community groups that address broader social determinants of health, like housing and safety. There would be investments to grow a broader and more diverse maternity care workforce, and training for providers on reducing bias and discrimination in healthcare delivery, just to name a few. And a very important issue for parents is paid leave. And I'm going to turn it over to my colleague, Michelle Long, now to talk about the latest developments on that front.
All right, thanks, Usha. My name is Michelle Long, and I'll be providing an overview of paid family leave in the United States and around the world, as well as an update on federal paid leave legislation. Next slide, please. Paid leave can help workers meet their family health care needs with greater financial security when they need to take time off work to recover from childbirth, to care for a new child, or to care for a seriously ill family member. Looking at paid parental leave specifically, nearly every other country and every wealthy country, except the United States, has a national paid parental leave program. The federal FMLA allows for 12 weeks of unpaid leave in the United States, but it's not available to all workers. Access to paid parental leave around the world often varies by gender. In this map, countries shaded in yellow provide paid parental leave only to new mothers, and green countries are those where both new mothers and new fathers have access to paid parental leave. Red countries do not provide any. Next slide, please. The duration of paid parental leave and the share of wages replaced while taking leave also varies by country. This table shows the duration of paid leave and the average wage replacement for new mothers and new fathers among a select group of OECD countries. Among all OECD countries, the average duration of paid leave is about 1 year for new mothers, and more than half of countries provide at least 2 years. The shortest duration is 12 weeks. When it's available, most countries provide substantially less paid leave for new fathers. Among OECD countries, the average duration for new fathers is 9 weeks, and the shortest is just 1 week. Many countries that offer a longer duration of paid leave provide lower wage replacement and vice versa. For example, the 12 weeks you can see there for Mexico provides 100% wage replacement, while Norway's 86 weeks of leave are replaced at just 46% of regular pay. Next slide. There's rich and robust research on the health and financial benefits of paid family leave in general, including improved mental and physical health for birthing people and increased likelihood of initiating and continuing breastfeeding. Access to paid leave also can help women remain in the workforce and advance their careers. Studies have also shown the importance of paid leave for new fathers, particularly when it comes to bonding with a new child and sharing caregiving responsibilities with new mothers. Both parents are also more likely to report increased sleep and improved mental health when both parents are able to take leave. Paid parental leave is also associated with a decrease in infant mortality, increased access to preventive care, and better health overall for infants. Access to paid family leave can help caregivers, most of whom are women, to maintain a connection to the workforce, and it provides them more financial security, both in the short term and in the long term. People with access to paid leave are also less likely to go into debt and are less likely to enroll in public assistance programs such as SNAP. Next slide. Although the US doesn't have a national paid leave program, 9 states and DC have enacted a patchwork of laws providing these benefits at varying degrees of comprehensiveness and generosity. These are the states shaded in blue in the map. Paid parental leave durations range from 4 to 12 weeks, and some states offer an extension for pregnancy-related health issues. Wage replacement ranges from 60 to 100% of regular pay, up to certain dollar caps. Some states provide benefits on a sliding scale with a higher percentage of wage replacement for lower income workers. 4 of these programs are administered through existing state temporary disability programs, and all are forms of social insurance, similar to Social Security, that require employers and/or workers to contribute to the cost of providing these benefits. I would also note that starting last year, federal government employees are entitled to 12 weeks of fully paid parental leave after 1 year of employment. Next slide. The 2021 National Compensation Survey from BLS found that in total, about a quarter of US workers have access to paid family leave, either because their employer offers it voluntarily or because they're required to by a state mandate. And this is the orange bar on the left. But as you can see in the blue bars, there's wide disparity in access, with far fewer part-time and low-wage workers and workers in service occupations having access to paid family leave through their employer. Next slide. The current version of the Build Back Better Act contains a provision creating a national paid leave program. Unlike the paid leave laws that have previously been introduced in Congress, which requires 60 votes to pass in the Senate, this one is going through the budget reconciliation process, which requires just 51 votes to pass in the Senate. If passed, beginning in January 2024, virtually all workers in the United States would be entitled to 4 weeks of partially paid family and medical leave. The amount of pay replaced while on leave is based on a sliding scale, with lower wage workers receiving a higher share of their regular pay. Workers at all wage levels would be eligible for at least some pay, but the benefits formula stops calculating for wages above $62,000 a year. Unlike state paid leave programs, which you'll recall are funded by payroll contributions from employers and/or workers, the paid leave program in Build Back Better would instead be funded by general revenues. There are a few novel provisions of paid leave in the Build Back Better Act that set it apart from parental leave in most other countries. In recognition of the changing paradigm of gender roles and caregiving, as well as the wealth of research demonstrating the importance of paid leave for both new parents, Build Back Better would provide leave regardless of gender, and the duration of leave and the pay replacement would be the same for all new parents. Build Back Better also recognizes the other ways in which people build their family, including adoption and foster placement, and provides the same amount of leave for these reasons. However, at just 4 weeks, the duration of paid leave in Build Back Better falls far short of what workers in other countries are entitled to. Even though passing this legislation through budget reconciliation requires a simple majority to pass in the Senate, its fate is still uncertain. And some moderate and conservative Democrats have expressed concern about the price tag of the legislation as a whole. Paid leave was already cut from 12 to 4 weeks during the last round of negotiations, and pay replacement was also reduced. Other benefits were also cut, such as 3 days of bereavement leave and grant funding for small business to be able to provide these paid leave benefits. Absent a federal paid leave law, access to paid family leave will largely continue to depend on where a person lives and works. Enacting a comprehensive paid family leave program would mean increased federal spending, but as we can see, it would have tangible health and economic benefits for workers and families, as well as put the US on a closer footing with other wealthy countries. Now I'll turn it back to Alina for Q&A.
Thank you all for a terrific panel. What I'd like to do is request, if you have questions, please put them in the Q&A section, not in the chat, in the Q&A section at the bottom of the Zoom screen. And we're getting some really terrific questions. So with that, I'm actually going to get started here. The first one is for Laurie. It says the US constitutional provisions in the 14th Amendment that support Roe and Casey also support contraception from Griswold and Eisenstadt. Do you think that if the court overrules Roe, and Casey that conservatives will also go after contraception? And if so, any guess on how receptive the Supreme Court might be to those anti-contraception initiatives?
I think that there's definitely a movement among conservatives. In fact, the Right to Life from Texas submitted an amicus brief in Dobbs asking exactly this, going after the right to contraception. Along with that, the right to marry who you want, both in terms of same-sex and interracial, the right to intimate relationships. So there's a whole slew of rights that are potentially at risk. It's not clear to me how the court would react to these arguments. Abortion seems to be in its own class, so to speak. They may or may not be less receptive to these other arguments, but certainly there's a conservative movement to go after them. So we'll see what happens with the next kind of challenges, depending on how the court rules in Dobbs.
And we've also, of course, seen in the Hobby Lobby and the Zubik cases where we have had conservative employers who have had objections to contraceptive coverage as well. So there has been a precedent for that as well. The next one is for Brittni. The Title X network rebuilding sounds promising. If SCOTUS overturns Roe through a decision on Dobbs, how is this going to impact the Title X network rebuilding?
Yeah, that's a great question. It makes the Title X rebuilding even more important. And I think this new increase in budget too, if we could pass $500 million for Title X, that could really allow the network to expand more than it ever has, to provide services to clients that need emergency contraception or any form of contraceptives. And it looks like the administration is really paying attention to this with their response to SB8 by sending additional funding to Texas. It remains to be seen like how many states they would have to send funding to, but I think it's a great way to expand contraceptive access.
Thank you. The next one is for Usha. Can you talk about how the Medicaid expansion provisions in the reconciliation bill compare with the postpartum provisions? What more will the postpartum provisions do if we have a supplement to the subsidies that are now allow people in the coverage gap to get private coverage?
Sure. So really, if these two provisions in the Build Back Better legislation, if they remain and they're enacted, I really think they would work together in terms of perinatal care and coverage broadly. So the postpartum extension that's proposed right now would be required in all states. So all states would see extension to 12 months postpartum for beneficiaries. So that really provides, stabilizes coverage for those who have had Medicaid funded births and provides both continuity of coverage and also access to the same providers. So continuity of care for those beneficiaries. The provision related to subsidies for private insurance in the federal ACA marketplaces, those are really targeted at the non-expansion states, those 12 states that have not yet expanded. So those could provide access to coverage for those who are really left out of the Medicaid program. So for example, in particular, I'm thinking for people before pregnancy. And we know that improving maternal health means really providing care before, during, and after pregnancy.
Thank you. And here is a question now for Michelle. It's a little bit asking you for a crystal ball here, but with the 4 weeks of paid leave currently in the reconciliation bill, do you think there's hope for other federal legislation, such as the Family Act, that will provide more comprehensive paid leave, like 12 weeks of paid leave, which is the standard in many other countries?
I'll do my best to predict the future. So as you mentioned, the Family Act was first introduced several years ago. It has not obviously been passed yet. The trick here is that, as I mentioned, the Family Act, for example, would require 60 votes in the 60 votes in the Senate to pass. And so that's where it gets kind of tough, because you have to obviously be able to get a lot of senators on board. And right now that would be probably pretty tricky to do, to get that many votes. The difference with the Build Back Better paid leave right now, of course, is that it's being passed via budget reconciliation. So in theory, that would have a better chance of passing in the Senate because it would only require 51 votes. So I don't think that paid leave is going to go away, even if it gets cut from budget reconciliation, and we could certainly see it pop up again in Congress outside of reconciliation. And I still think that we're going to keep seeing more states pushing for paid leave laws in their own states as well going forward.
Thank you. The next one is for Laurie. I'm wondering, the question is, how might medication abortion address the access problems in people in states that may set gestational limits if Roe is overturned?
So there's been a lot of attention recently about medication abortion. For those that don't know, the FDA has their own requirements around the suspension of mifepristone, which requires an in-person suspension and by only certain providers. So it's not a drug that you just pick up at the pharmacy. The FDA is currently reviewing those rules and is expected to have a decision soon. But that won't mean access equally across all states, because some states have their own rules around requiring either in-person suspension or specifically banning telehealth. So it will be mixed. And as you can imagine, many of the states that have those restrictions are the same ones looking at very strict gestational limits if Roe is overturned or modified. So in terms of being able to provide out-of-state care to people in those states, providers have to abide by the state laws in terms of treating a patient in a certain state. So it will be challenging to reach people in states that have gestational limits with medication abortion.
Can you talk a little bit more also about what you would expect to be the aftermath if Roe is overturned at the state level?
Sure. So I think it will be a hodgepodge, and it will be very confusing for both providers and for patients, because some states will look to strengthen and protect abortion laws, while other states will seek immediately to try and ban abortion to the maximum amount allowed by federal law. But then there's probably states that will have their own gestational limits. Some will be 6 weeks, some might be 10, some might be 12. And it might be changing, given what they're newly allowed to do. So it will be hard to track and to reach patients and to let them know what their rights are in their particular state. And then, of course, people will be looking to access care outside their state, and those states around those states will also have changing gestational limits. So it will be a mess in very technical terms.
Yeah, I think it's hard to know for sure. In some places, it's pretty clear what will happen, but I think in others, and especially the outcome of this election, I think will also determine what we will see. This next question is for Usha. We've got a lot of comments here about Medicaid eligibility. Someone who wants us to clarify that Medicaid coverage eligibility for those who are pregnant and undocumented is also particularly difficult, and there are few options for those, particularly postpartum. And another question here, patients often prefer physicians and healthcare providers who look like them or who share their background. Do you know of programs that are encouraging Black, Hispanic, and Native American OBGYNs, as well as labor and delivery nurses and other midwives and doulas, to combat maternal and infant mortality in communities of color?
Yeah, that's really an area of interest that we've seen at the policy level, at the federal and state levels. Some of the provisions, I went through them quickly at the end there, but there is a set of federal bills packaged together called the Momnibus. Several provisions from those bills address some of these issues, particularly around stemming racial and ethnic inequities in maternity care. And part of that has to do with workforce. And that is diversifying the workforce, broadening it, support for more community-based providers like community-trained doulas, community-based midwives, and really trying to figure out how to incorporate them into existing systems, into the existing healthcare system, into the existing payer systems. Some of the policies from those bills are included in the current version of the Build Back Better legislation. So that would be, right now there is proposed funding for both training of providers and really shoring up the pipeline of future providers and making sure that it is more diverse and broader and reflective of the communities that they serve. There has also been at the state level, a lot of states expressing interest in trying to provide Medicaid coverage for particularly doula services right now, which is only available in a couple of states, and even that not necessarily throughout the entire state. This has been an area, like I said, that there's been, I think that states are really trying to figure out how to incorporate newer providers and community-based providers into the Medicaid payer system. But there has been a lot of interest because we know research has really shown that having a support person can really help with maternal health outcomes, particularly for communities of color. So there's a lot of work underway. It's in various stages. I would say another area where we're seeing a lot of work on the maternity front is about really shoring up the delivery system in some areas that are underserved, particularly some rural communities where in some places there might be just not as many hospitals, not as many providers on call, where people may have to travel long distances, particularly in the case of an emergency. So there are funding streams proposed in the federal legislation, all those levels, and some of the states have also taken action.
And I just want to give a little bit of a shout out. The Medicaid program really shapes coverage for many of these services as well. We're in the process right now of analyzing a survey that we did of state Medicaid programs on their coverage of maternity care and family planning services. So we'll have a lot more information and detail about what states are doing with their programs as well. This next question is for Brittni. The Trump administration expanded Title X funding to non-licensed and licensed religious crisis pregnancy centers. Do the new provisions, the regulations limit participation of these organizations and limit the harms caused by these organizations?
Yeah, I think two aspects of the new regs that were part of the program prior to the Trump regulations were having to provide a broad range of contraceptive methods. And now it's gone even further to say you have to provide a referral or a prescription for a method that a person wants. So they have to be willing to do that. And then providing options counseling too. If a person requests option counseling and wants their full range of options, referrals for an abortion provider, adoption services, or prenatal services, they have to be willing to give those as well. So I do think that may deter some people from participating in the program. And we know that clinics like the Obria group that became a grantee under the Trump administration in California, they are no longer part of the program as of April 2021. So I think that could determine whether people participate or not.
Thank you. The next question is for Michelle. A lot of employers actually looks like they made some changes to their paid leave programs as a result of the pandemic. Can you talk a little bit about how the pandemic affected access to paid leave? And do you expect any of these changes to be maintained?
Sure. So we actually just released a week ago, I think it was, a new analysis on how employers have changed their paid leave benefits during the pandemic. This is part of our annual employer health benefits survey. And so, as you've probably heard, a lot of employers announced that they were going to make changes to their paid leave program, whether that was their sick leave program or their paid family leave program in light of the pandemic, in order to give workers the opportunity to, be able to take care of their families and their own illnesses without having to sacrifice so much of their pay to do so. And so our survey asked employers how they had changed their paid leave benefits, both paid sick leave as well as paid family leave, during the coronavirus pandemic. And what we found was that overall, almost 4 in 10, 37% of workers work at a firm that either expanded or began offering paid leave for the first time during the pandemic. And just to break that down a little bit, most of that change is coming from paid sick leave. So About a little over a quarter of workers are at a firm that expanded or enhanced their paid leave benefits during the pandemic. And a smaller share, 4%, began offering paid leave for the first time, paid sick leave for the first time. And about 17% of workers are at a firm that either expanded or began offering paid family and medical leave during the pandemic. And what's interesting here is that we already know that larger firms are more likely than smaller firms to provide these paid leave benefits in the first place. And so what we saw was that large firms are more likely to be the ones expanding or enhancing their existing benefits. And we saw more smaller firms starting to offer those benefits for the first time. We also, the last year had the federal emergency paid leave program, which required employers to provide some paid family and sick leave. And that expired at the end of the last year though.
Thank you. And this, I think, is going to be our final question, and this is for Laurie. There have been a lot of questions about abortion and medication abortion. And this is about ordering medication abortion pills from services such as Plan C. Do you think that various levels of government will be able to prevent people in red states or states that ban abortion or from ordering the pills from another state through telemedicine in the mail? You touched on that earlier. Will the strategy be for states to enact extreme penalties to anyone caught, as some states are doing? You could comment on that.
I think this is an open question. Certainly, it's a strategy of people who are concerned about abortion access to make it available through the mail. But again, as I said earlier, providers who send it to people in the mail are essentially practicing medicine in that state, and so might be hesitant to do that if it's not allowed in that state. The other aspect of this in terms of criminalizing people that help, we've seen criminal penalties for a long time on the books for providers, and it's definitely a deterrent to providing, this has been on the books for gestational limits. Texas's SB 8 is a different strategy and essentially making anyone able to sue anyone who provides or aids or abets an abortion with a civil penalty starting at $10,000. So I'm not sure which way we'll see it, if it will be civil or criminal, but there's definitely many ways in which states can deter people from helping other people obtain abortions, either through medication or through procedures. So the states that want to do that, I expect will do that.
Thank you. Unfortunately, we are practically out of time. So I would like to just wrap things up here. As I mentioned in the beginning, there's just so much in play right now. We're going to know very soon about the outcome of the reconciliation bill, which will shape what's happening with the Medicaid coverage gap, as well as the Medicaid postpartum extension and paid leave. The Hyde Amendment is still, the House has passed a budget without the Hyde Amendment. It's not clear what the Senate will do with that, as well as the Women's Health Protection Act. The administration is, I know, working hard to rebuild the Title X network and has many initiatives as well to improve maternal and health outcomes through work that's going on as well through at HRSA, and also defending abortion rights as they have in Texas. And the states, of course, are going to be increasingly important in terms of decisions around implementing the postpartum extension and looking at how we will support a Medicaid expansion, as well as abortion access and paid leave. And then finally, in a few weeks, we're going to hear the oral arguments around the future of abortion in the Mississippi case and in Title X as well. Although that's not a case that's at the Supreme Court, it is definitely at the courts and will be moving through. So with that, I just want to thank everybody. I want to thank, this is a great panel. We covered a lot of ground in a very short time. This webinar will be available probably later today, and you will all receive a notification via email when it's available. So I encourage you to check with kff.org. We will certainly be following the developments over the coming months and years ahead. Thank you.